Good afternoon. So I'll be discussing which coils do I use for treatment of ovarian vein and hypogastric varices. And the reason I'm doing this is because I work in an OBL setting, and the OBL has a peculiar modality in terms of what we select for our patients and what's cost-effective and what's effective and safe to use. These are my disclosures, my facility in Charlotte. So just to recap, pelvic congestive syndrome, we've been bombarded with all this information, but I think it's very important to just recognize again how significant this can be in a female patient. Chronic pelvic pain, pressure in more than 6 months, usually is an indication of something's going on. Unusual degree of discomfort with menstrual cycles, pelvic pain during or after sexual intercourse. This could be detrimental to a couple because this, can make or break a relationship. Feelings of fullness in the pelvic region, vaginal region, labia, perineal region, swelling in the vagina, the labia, and the perineal region also are noticeable and sometimes significant. Hence the reason why we should do a good clinical examination, good physical examination on our patients. Varices present in the upper thighs, in the vaginal labia, and the suprapubic area, as well as the perineal region. Frequency of urination, and stress incontinence. All these things have to be investigated, and you have to understand these symptoms before you make a decision to operate on a patient. Embolic coils are of all sorts of sizes and flavors and different manufacturers, and this is not a great slide, but this just gives you the ample view of just 2 different companies, Boston Scientific and Cook, that have provided detachable coils as well as pushable coils. At SCGVS, or South Charlotte General and Vascular Surgery, we've selected the Nestor coil. The Nestor coil has been very cost-effective, and it's also very effective because it creates this thrombogenic effect in the veins that you're thrombosing. It's a very elegant coil, as you can see, made of platinum, and it has these hyperthrombotic fibers on it. So the characteristics of the Nestor coil comes in different lengths, from 2 to 20 centimeters in length, and diameters ranging from 2 to 20 millimeters. They can be delivered through a 0.35 platform or a 0.18 platform. Nestor coils conform inside the vessel to create a tight occluding mass, and it's very important that we create that tight occluding mass, or else these coils will not be very effective in the long haul. Nestor coils are suitable for use in starting your coil embolization, packing, as well as finishing. You can do a combination of pushable coils or detachable coils, or maybe an Amplastor plug, etc., just to be thorough and complete depending on your morphology. The synthetic fibers, again, promote clot formation. This is key because if the fibers were not there, I don't think the coil embolization would be extremely successful, and you would have complications such as recanalization. The beautiful thing about these coils, they're very easily visible on fluoroscopy, and they're also MR conditionally safe for Tesla 3 and 1.5. So, and it can be, again, used combined with detachable coils. This is another depiction of the thrombogenic fibers on the coil. I just added this. This is the variety of coils that are available to us. But overall, in the OBL setting, what we're interested in is the economic value analysis. And when you talk about economic value analysis in the OBL, this, especially a procedure that's not reimbursable, is something that you have to take in consideration, because an OBL has to run, and we have to have influx of cash to maintain our employees, maintain our staff, and our materials. So this analysis shows you the estimated number of coils per procedure and then the total cost of coils per procedure. And you have a comparison between pushable Nestor embolization coils and the number of 10 and the detachable coils and the number of 5. So if you use 10 coils, Nestor coils, it would cost you about $991. If you're using detachable coils, the cost goes up astronomically, $4,270. So you can do a combination of detachable coils with pushable coils, and you can see that your cost can drop to $2,302. And if you did 100% pushable coils, which is completely feasible because you have the lengths, you have the diameters that are adequate, your cost significantly goes down. But there is a caveat, which I'll go through later in this talk. So the product recommendations for its use, obviously the manufacturer will recommend the adequate glide catheters to deliver this, the type of wire to deliver it, and I would follow all the guidelines because you can get into trouble if you use the wrong products to deliver these coils. These are the ones recommended by Cook for the Nestor. The other thing that's very important when you're doing these coil embolizations, and this has probably already been talked about, but is understanding collateral vessels and collateral flows. You have to remember that coil embolization is permanent, and you're going to have redirectional blood flow. And many times it will activate collateral flow that you did not detect before. And with Dr. Pena's comments about treating these in a staged manner, I completely agree. And I do it in that manner as well. I treat the iliac venous compression first, and then I assess my patient a few weeks down the road to see how their symptoms have improved. And I do see a lot of improvement in symptoms. But in the long haul, they come back with continuous symptoms of pelvic congestion. So we investigate further and we treat. Usually when we do these patients the first time, we do a thorough venography. So we select the left renal vein, we do left gonadal vein or ovarian vein, we shoot dye, we confirm the grade of reflux, etc. We've used IVUS. So we have a thorough understanding of what's going on. But we only treat in segments and we assess the patient for symptom relief. So coaxial technique is recommended to prevent coil elongation. And this is sometimes when you're using this in the beginning, it's very difficult to obtain, but you need to have stability of your catheter when you're pushing those coils. As soon as that catheter gets pushed out, then you're going to elongate the coil. It's very hard to obtain, the perfect packing. You may have to use more coils than you have planned for. So there you go. There's a depiction there of how you can tightly pack and dense the coils into a mass. The initial cross-sectional occlusion in this image, in the first image above, you can see that's an inadequate packing, and many times you'll have that, and you'll have to go back and put another coil in there to densely pack so you get the appropriate result. This is a cross-sectional occlusion that was ineffective, and this is a patient 5 years post-embolization. As you can see, the coils are there, and that vein is relived, and it's pumping again and creating its havoc on the patient. Selective ovarian vein catheterization here in our clinic. You could see a large vein that's probably larger than 6 millimeters. We shot, this is a hypogastric selective venography, which you could see quite dilated. This is on the same patient. And this patient had a staged procedure. She didn't have venous compression, but she did have ovarian vein reflux as well as internal iliac vein reflux. Intravascular ultrasound, just like on the arterial side, has also revolutionized the way that we treat the venous side. Not just May-Thurner syndrome, but also understanding the morphology and the size of the ovarian vein and making the right decision of which coil you're going to be able to use. This is a little boring. We'll go to the next one, which gives me a nice measurement. So this is minimum diameter for this ovarian vein, and this is in the distal ovarian vein just above the pelvis, is 6 millimeters by 8.7, its max diameter. So this patient got a 8 to 10 millimeter coil. You can see here the first coils were kind of elongated, and that was due to the catheter and the lack of support. Now what I do is I take a 4 French sheath all the way up into the ovarian vein, giving me a little bit more support, and then I take a 4 French glide catheter along with my coils. That way I have more stability and I can deploy my coils successfully. This patient did extremely well after this. Her symptoms subsided. And actually, after about 6 months, she returned again, complaining of some more pelvic pain that she didn't have before. And this is the redirection of your collateral flow. So when we did her hypogastrics again, the hypogastrics were still very dilated. And so we ended up coiling those hypogastrics, and her symptoms subsided. This is a gonadal vein embolization on a young dancer who complained of a lot of pain, a lot of heaviness in the testicles, had large varices, and he was just very uncomfortable. And every time he danced or was doing anything strenuous, he would have a lot of pain. He had a successful coil embolization, his symptoms subsided, and he's still dancing at Broadway successfully. This is post-embolization. You can see that there's no thrombosis just yet. but later on we have good results. This is another male who had coil embolization. So coil embolization is a minimally invasive approach to treat these without leaving scars behind. Unfortunately, we have to leave foreign bodies, but these foreign bodies become inert, and our bodies just, get used to them. Unfortunately and sadly, insurance companies do not cover this procedure because they consider it experimental. So patients have to absorb the cost of the coils. But we have to remember that, yes, we can select the veins and we can do a venography, and the insurance company will cover that. So at least we have some mitigation of our costs. At SCGVS, we help our patients by giving them a payment plan and to facilitate the cost. And usually the procedure cost is it's not very high, and about a third of the cost is the coils. Thank you very much.